Okay, there we go. Now I can hear this. Again, I'm Christine Kay. I'm a vitreoretinal surgeon, and I'm an inherited retinal disease specialist. And I'm located here in Gainesville, Florida. This is my practice, Vitreoretinal Associates, our group back here. Gabby, wave if you want to meet our practice group here. This is a couple of people from my practice. We're up in the Millennium Building in Gainesville, Florida. We have a site in Ocala and a site in Lake City. I see many of my patients out here in the room, and I'll obey my HIPAA privacy laws, so I may not come up and hug you and say hi to you, but I do recognize many of my patients, familiar faces out there, so thank you for being here today. Let me just first poll the crowd here. I'd like to know who's in the room, and if you don't want to raise your hand, again, HIPAA, privacy, you don't have to, but who in the room is very, very interested in hearing about diabetes today? Okay, a little scattering here. And who in the room is very interested in hearing about macular degeneration today? Okay, so good. That's what we sort of thought, and we're going to probably spend the majority of our time on macular degeneration today, but we will start with a less than 10-minute overview of diabetic eye disease. And if you're not personally involved with diabetic eye disease, you may have a family member who is, because we're just about to see some prevalence data on diabetic retinopathy. So I guess the best way, I don't have a screen to see my slides, right? I'm just gonna kind of stand here and look. So diabetic retinopathy is extremely common. Diabetes is one of the leading causes of visual loss in the US and globally as well. We used to define diabetes a little bit differently than we now in modern era define things, so we're moving a little bit more from the traditional insulin-dependent diabetes, non-insulin-dependent diabetes, and age being a factor, to more of an immune-mediated disease understanding instead of type 1. And then we understand now, very importantly, that there's an increasing level of juvenile onset diabetes and even adult onset diabetes because of obesity and other factors in the US. So I'm going to move into this. So that latent autoimmune diabetes, adults 10 to 20% with adult onset diabetes, often over 35, usually non-obese. This is more of an immune disease. This is the epidemiology slide, which is, I actually tried to get this updated last night. So 38.4 million people, that's 11.6% of the population, had diabetes in 2021, with 29.7 million cases, diagnosed cases. So that incidence, that means how many people get the disease in a given year. About 1.2 million Americans are diagnosed with diabetes each year. So if you aren't affected, you may have a family member who's affected with diabetes, and diabetic eye disease is an extremely damaging disease that can be prevented and really can be managed, prevented. If not prevented, managed very carefully, and patients can still do well if we catch things early and don't miss it. The children is an important point here. Children and teenagers are really increasing in our diagnosis of diabetes. 151,000 under age 20 have diabetes. Most have type 1 diabetes still, but there's increasing incidence of this type 2 diabetes, which we think of as the insulin-resistant diabetes in children and adolescents. The contributing factors being obesity, decreased physical activity, kids playing on their iPads rather than outside running laps and playing baseball in the field, maternal gestational diabetes. Delayed diagnosis is very common with childhood onset because the symptoms can be unrecognized, and parents can diagnose, patients can present in DKA, diabetic ketoacidosis, with a hospital visit. Worldwide epidemic, in 1985, an estimated 30 million people had diabetes. So top countries, the top 10 diabetes countries are India, China, USA, Indonesia. You can read this up here, but this is really a huge global problem of diabetes and diabetic retinopathy. In 2005, an estimated 1.1 million people died from diabetes. The World Health Organization projects that diabetes deaths will increase by more than 50% in the next 10 years without urgent action. We'll just go through. So the Wester was this, I just mentioned that the Wisconsin epidemiology study of diabetic retinopathy, really old study, but still really helpful in understanding the relevance of diabetic eye disease and diabetic retinopathy. After 20 years of diabetes, 99% with type 1 and 60% with type 2 have some retinopathy, and that means eye disease, so retinal blood vessels are affected. After 20 years of diabetes, 3.6% with type 1 and 1.6% are legally blind due to their diabetic eye disease. So really tragic numbers here. We're going to skip through this because I want to start showing you what it does to the retina. So this is my favorite territory, not the epidemiology, but what it does to the eye. So I'm going to show you, if you just pathophysiology kind of mechanisms of what it's doing, and then shows some pictures of how we deal with this. So it's microvascular damage. The little capillaries in the retina are trying to perfuse the retina, and those blood vessels are abnormal because of diabetes and abnormal blood sugar levels. So microvascular pathology, endothelial, parasite loss. I'm not going to use a ton of words today. I understand that we're not going to necessarily focus on the pathophysiology, basic science, but basically capillary dropout, which means the blood vessels are no longer bringing blood flow. Your retinal doctor will call that non-perfusion. Non-perfusion meaning blood flow. So an area that can actually die. So the word there is retinal ischemia, which means lack of blood flow, and infarct, which we use that word for a stroke, where the brain doesn't get blood flow, and that doesn't do well. And I always tell my patients, think of your retina like your brain, because the cells are actually very similar. Brain cells don't rejuvenate. We all understand that. We've heard of patients, or we have patients in our family, or we may have had one ourselves, a stroke, that usually the function deficit can be permanent. The retina is the same. So those retinal cells are neurons, photoreceptors, the cells at the back of your eye that sense light and allow you to see. Those cells do not regenerate. If I cut my skin open, it's going to hurt, it's going to bleed, but it's going to scar, and eventually it'll grow back in. Doesn't happen in the retina. So that's really sort of a very important point that I talk to my patients about, that these retinal cells are neurons, they don't regenerate. So in a diabetic eye, the area of the retina is getting, let me see if my laser pointer is working, anything black here is no blood flow. So this patient would probably be count fingers vision because they don't have any blood flow to the retina. And we can't in modern medicine fix that. I never say never, maybe we'll invent a way to fix that, but right now we can't fix that. We can't bring that blood flow back and bring that retina back to function. But what happens when it's doing that is that the retina actually recognizes that it has no blood flow, and it starts to grow new little bad blood vessels into the retina called proliferated vessels or proliferative disease, and the retina then breaks into a hemorrhage or a tractional detachment, and then we're doing these really difficult surgeries that I'll show you a few pictures of. But before that, other bad stuff is happening that we can treat. So a little edema, which means swelling of the retina, is one of the first things we see, and we can treat this. Again, we can't fix the fundamental problem, that's the sugar control and the systemic disease, but in a retina clinic, we can temporarily treat swelling in the retina by injecting drugs into the eye and sometimes lasering. So here's a patient with mild diabetic retinopathy, little hemorrhages, and these are called exudate, which is like a lipid-like material that leaks from the vessels. Diabetic macular edema, you see this is a fluorescein angiogram. We inject the arm of the patient with some vegetable-based dye called fluorescein, and we see that everything that glows here is actually leakage from these very permeable vessels that are very abnormal. And this helps us if we're going to add some laser. We're going to use this to guide us of where to laser. And this shows a fluorescein where a patient actually has neovascularization, where we're going to end up needing to target some laser to shut that bad process down, or else the patient will hemorrhage and have a detachment. This is what the retina looks like. That black circle in the area is abnormal. That should be nice and flat all across. That's, imagine a sponge filled up with water. That's what a diabetic macula looks like. It's full of water, but it's not really water. It's intravascular leakage, exudate material. And so that blurs the vision. You can imagine you're looking through a sponge that's full of fluid, blurry fluid, and so the vision is blurry. This is an OCT image where it shows some of those abnormal layers and fluid. And this is an example of neovascularization, proliferative diabetic, the worst eye disease where we grow new blood vessels and leak and bleed. Severe NPD are big areas of detachment. This patient is severely detached and into a scar tissue detachment. This would be very difficult for me to even try to repair operatively just to stabilize, but there will be likely no good vision coming back from this eye no matter what we can do surgically. Anterior segment can also, the front of the eye can also become problematic and it can bleed. This is called a hyphema. The eye is literally full of blood. And that means the inside of the eye, called the anterior chamber in front of the patient's lens, is full of blood because the inside, the iris, your brown or your blue, whatever people say about your color of your eyes, that's your iris. And that is full of blood vessels and bleeding. So obviously this eye is very sick, and the next thing is that the pressure goes to 60, and the patients develop neovascular glaucoma, goes blind from high pressure, or needs a tube in their eye. So these patients' eyes do very badly. So what do we want to do? We want to emphasize medical management. Let me just not skip that slide because that's important. optimize the diabetes management is really number one. Manage their comorbid diseases. When these patients' eyes look like that, I always ask them, how are your kidneys doing? Because usually they might also be in kidney failure or not even know they're in kidney failure. Often the retina and the kidneys are doing similar things at the same time. So we learned from that diabetic retinopathy DCT results, one of the trials we've done, when compared to conventional therapy, intensive blood sugar therapy resulted in 27% reduction in the development of retinopathy. Okay, I'm going to finish this up. That's when I wanted to finish my diabetes talk. So we're going to just show a couple interesting pictures of what happens. This is laser. We add laser to make the retina stop bleeding and try to prevent a detachment. Laser actually patients tolerate fairly well. It causes a bit of a headache, and we do that usually in 1 or 2 sessions, and patients can have a poor visual field after having had laser. And then I want to just finish with what happens with injections. You've probably seen this before, and we're going to talk about this in AMD too, but diabetes patients get injections in their eyes as well. Interestingly, they get the same drugs. The anti-VEGF drugs work very well for this disease, so we do directly inject into the white wall of the eye called the sclera. This location is the pars plana, so it's about 3 millimeters outside of the limbus, which is the edge of the eye. You can see a speculum is used. We often use gloves and betadine prep the eye, and then we directly inject into that white wall of the eye. So it's an intravitreal injection. And then surgery. So if things go badly and we catch things very late, then the eye detaches. This is a bad tractional funnel detachment. And I just want to show you a couple pictures, not to scare everyone, but this is what happens when diabetes is caught really late. This patient might be 20/20 when they come into me and have a little spillover of floaters, and that's always my most difficult. Like a 30-year-old terribly managed diabetic comes in and they have a few floaters, and then I look in the eye and it looks like this. So things aren't going to go well. This patient's going to need surgery and have silicone oil and vitrectomy, and we can maybe stabilize, but we often catch things right before, either when they're too late or when they're about to be precipitously declined. This is what a vitrectomy looks like, and then we'll move into our AMD talk. But we set up surgery, set up 3 trocars, an infusion cannula, microscope. Everybody close their eyes if you don't want to, while you're eating, look at boring pictures of surgery. I'm just warning you, but this is what a normal surgical setup looks like. And we're under an operating room. We're under an operating microscope. So basically, when I operate, I'm looking at a microscope down into the patient's eye. And our take-home slide here is follow-up and seeing your doctor and doing your annual eye exams when you just have a diagnosis of diabetes. And if you do start injections, don't stop, don't not follow up, and don't ignore it. This disease does not do well when you ignore it. Okay, any questions about diabetes?
Oh my God.
Okay.
Questions at the end.
Questions at the end, never mind, you're not allowed to ask me questions. Okay, now we're going to smoothly transition to macular degeneration. Let me drink my Sprite more. Okay, I'm still the same person, so I don't have to reintroduce myself. So we're going to talk, and it's a little bit on the schedule kind of merged, but basically I'm going to do an overview of dry macular degeneration and wet macular degeneration. I figure I should overview the pathogenesis of these diseases first, and then I'm going to tell you some updates in the treatment of dry AMD. Was anyone aware that we have 2 FDA-approved injections for geographic atrophy? Okay, we'll talk about those drugs. And we have gene therapy trials. We have stem cell therapy trials. And then we'll move into, so that's for geographic atrophy, and then we'll do updates in the treatment of wet macular degeneration. Again, we'll talk about the standard of care anti-VEGF and repeat treatments, and we'll talk about clinical trials that are some sustained therapies. So AMD is the most common cause of blindness in the Western world. 7 million in the US have drusen. 1.75 million people have advanced AMD, and by advanced AMD we mean geographic atrophy, which is the advanced form of dry macular degeneration, or exudative macular degeneration, which is when the retina starts to bleed. And I'm going to show you the pathogenesis of both of these diseases. So 3 million or more, 2020 and on. Dry AMD is not, the other term you'll see in maybe your clinic notes, non-exudative AMD, characterized by drusen. This is an example of a large, soft drusen, and we like to be real creative, so we call them soft and hard drusen, small, intermediate, large. So but we do have ways of grading these drusen, and it actually does become important when we risk stratify a patient of the risk of progression. We count pigment spots, and we have ways of grading dry AMD of how likely they are to progress to geographic atrophy or to wet AMD. But by definition, they are not leaking fluid or blood, they're dry, and patients always ask, does that mean that my eyes are dry? We're not talking about the cornea, we're not talking about artificial tears, we're talking about the retina. So I always have to kind of explain that to patients, these words of dry or wet, nothing to do with my eyes feel wet or dry or tears. That's the cornea, the outside of the eye. We do categories early, intermediate, and advanced. Oops, that's the laser pointer. Okay, so this is an example, and you might not be able to see it with this lighting, but this area that's kind of carved out here is geographic atrophy. We'll see tons of photos, and we'll see better in autofluorescence where it's going to show black. But atrophy is where the retina is actually missing some of the layers of the retina. And so the RPE and the overlying photoreceptors are gone, and they've died because of disease progression. So that's what geographic atrophy is. Significant cause of vision loss from AMD. 3.4% of people over 75 have geographic atrophy. It's a surprisingly high number. Natural history of GA. Slow enlargement of an area of atrophy. This is this individual. Maybe three, we call it geographic because it's like drawing a little map and a geography chart. So these little areas are sort of three separate areas, and now they're confluent larger areas of atrophy, and unfortunately in this patient they've now encroached upon and covered the fovea. So that patient would be, if they're lucky here and still had a fovea, they might be 20/20. In this patient, they're likely count fingers. And that can be a precipitous decline over a few years where that central vision is sacrificed. Exudative AMD, to differentiate, there's a choroidal neovascular membrane. And ophthalmology gets really confusing because we talk about lots of membranes, but when we're talking about wet AMD, it's a membrane growing under the retina and a blood vessel membrane growing under the retina. It's not an epiretinal membrane where we can surgically peel it off. So we can't go peel it off, it's under the layers, it's in a blood vessel under the retina. So you can see the bleeding here is actually subretinal, and there's actually a fibrotic scar in different areas of this retina right here. Choroidal neovascularization buds within Bruch's membrane, which is a layer on the near the surface of the RPE, which are those important cells under the retina. Here's the choriocapillaris. This is some histopathology, so you see the layers here. So middle of the eye is up here. The first thing is the photoreceptors that light would be, if something were to be going from the inside of the eye to the back wall of the eye. Photoreceptors first, then the RPE cells, which is a monolayer, then this little Bruch's membrane that's supposed to be intact in a big barrier, and then underneath that, this very active blood flow area called choriocapillaris. And there's supposed to be this very perfect blood-retina barrier where blood does not get into the retina. We don't want blood in the retina. Blood is toxic to the retina. But we'll see in this disease, that's what becomes defective. And so there's this abnormality. There's an irregular breach of Bruch's membrane, and choriocapillaris vessels have busted through our intact Bruch's membrane, so it's no longer intact. Bleeding and scar tissue forms, so fibrosis, and anything bleeds, the body knows to scar, so at least it does do that, and it doesn't help the vision, it really hurts the vision, but it stops the active bleeding. So the eye, I always tell my patients, the eye is trying to heal and scar itself, it's just not doing a very good job. So we want to stop that process of scar tissue. And this scar tissue is extremely damaging. This is another one of those things that we don't have the ability yet in modern medicine or surgery to fix. So if you have a big subretinal fibrotic scar, we just can't go in there and chop it out and give you a new piece of retina yet. But I'll never say never. We're working on things like that. So here's fluid over the retina where the retina has this big membrane. And classic CMV, you see that perfect circular lesion with blood around the ribs. That's an active neovascular membrane. So we want patients to have timely, comprehensive exams. If you're just screening and have a few drusen, you maybe could go every 2 years. We often see patients every 1 year for dry AMD and doing well. We'll see you next year. Check your AMSLR. If they're having any abnormalities on their AMSLR grid, I might be checking them more frequently. There's limited evidence to just start ARIDS. People ask me, should I start ARIDS if I have nothing? And there's limited evidence that it's actually statistically going to help you. It's probably not going to hurt you, but ARIDS vitamins are expensive and they upset people's stomachs sometimes. So we don't tend to start eye vitamins just for the heck of it unless you have some drusen or intermediate AMD. So this is the ARIDS, the rate to advanced AMD, looking at patients who were the placebo group patients who got nothing and patients who had the eye vitamins, and basically the eye vitamins had an absolute risk, I I didn't mean to do that. And a significant absolute risk reduction if you were on the eye vitamins of your likelihood to progress to advanced AMD if you had intermediate or advanced, if you had intermediate AMD. If you had early AMD, which is the green one here, it didn't meet statistical significance start. But you can still take AREDS vitamins if your doctor thinks it's safe for you to take, and it probably doesn't hurt. We just didn't have the study long enough to follow for risk of progression over an incredibly long period of time. Management of patients with intermediate AMD, regular patient self-monitoring, exams, again, every 6 months to 12 months, photography, we might get fluorescein angiography, and the AREDS vitamins are useful in, again, the intermediate patient group. And what the AREDS vitamins aren't rocket science, they're antioxidants, so they're not a magic cure. I have a lot of people ask me which vitamin, which, we just look at the AREDS 2 data, so there's AREDS 1, AREDS 2, AREDS 2 data, vitamin C, zinc, copper, lutein, zeaxanthin, they got rid of vitamin A and the AREDS 2 vitamins, and they help slow progression, so here it is, I knew I had the slide, relative risk reduction of 25%. So that's very good. It doesn't halt disease, things it doesn't do. It does not halt disease, and it doesn't prevent 100% risk of reduction, but it's better than nothing, and they're good healthy vitamins that probably help other things since they're antioxidants. So drusen, this is how we size drusen. It's not incredibly relevant, but mild, moderate, and severe AMD photos here of hyperpigmentation. Again, this is kind of how we grade. So this one I actually really like. So I do tend to do this in my clinic notes and look at a patient's number of drusen and amounts of pigmentation and try to every now and then give them a severity score of, okay, Mrs. Jones, you have a 50%, if they have 4 scores on that, if they have a score of 4, they have a 50% chance of converting over a 5-year risk. You can barely read the best, it's 5-year risk of development. If they have a count of 2 for pigment and a count of 2 for size of drusen. And so those patients I might follow more frequently. Or I might recommend one of the home monitoring devices that we're going to talk a little bit about today with some of the other talks. So, updates and therapies. This is what we just mentioned that some of you were aware of. So for dry AMD, there are 2 FDA-approved drugs that were relatively recent, the last few years. The FDA, interestingly not the EMA, so Europe did not approve these drugs because there was not a functional improvement in vision, but the FDA did approve these 2 drugs just based off of their imaging. So at least for now, the FDA seems to be able to approve a drug just if the structure shows improvement, and that by this was autofluorescence images. The 2 drugs are Syfovre, a company called Apellis, and Izervay actually changed names multiple times. It was Iveric Bio, and then it was bought out by Astellas, and so that's the second drug. Very similar, both complement inhibitors. I'll show you a little bit of the differences of them. But that's 2 of the FDA-approved treatments, and then we'll talk about lots of trials in a little bit here. And then just switching to X-rated AMD for a minute. We're living in the anti-VEGF era of shots, but they're repeat shots. And so these drugs are antibodies, most of them, and they wear off and they have a half-life. And then we're back to square one. And I always tell a patient, I kid with them because they say, how many more injections do I need, Dr. K? And I always kid with them, and I wonder if I should maybe rephrase this one, but I say, well, this is like taking your blood pressure medicine, you can't stop. Luckily, we don't have to inject you every day. Your interval is every 12 weeks, but that drug completely wears off and we inject again because just like your blood pressure, this disease doesn't go away. And I don't know if that's a good analogy or not, you could maybe help me with that later, but the idea is it's repeat treatment because the drug doesn't last. It's a short-lived drug. However, we're looking at some sustained therapies and gene therapies and different devices and all kinds of interesting things. So we're working on sustained long therapies. This, I promised you some autofluorescence photos. This is an autofluorescence photo of development of AMD and different patterns that we look at for pigmentation and developing geographic atrophy. And here's some really good images of atrophy. So this is a well-demarcated of atrophy. This patient would be 2,400 or count fingers, a really large area of macular atrophy. There are still cells here, but the cells outside the fovea don't have the physiologic capacity or matrix to see better than 2,400 or somewhere thereabouts. So we would need, and I always say we would need, but we don't have it quite yet in prime time where we can do it, a stem cell scaffold, a retinal prosthesis. We would need something to replace. So those cells, we would need new cells. The cells are gone. Okay, so let's just look at, Okay, so now we're going to talk a little bit more, and we're going to talk about what's happening with AMD process, with dry AMD. So here's a drusen. Watch the drusen form here underneath the Bruch's membrane. And then what happens is drusen coalesce. This is why we already talked about the laser machine today and what that might be doing. So there is some potential of there is a new FDA approved treatment of lasering drusen and trying to stop this process. So the RPE thins, the choriocapillaris atrophies itself, so the blood vessels die, so that's bad, and then the overlying RPE dies, and then the photoreceptors die. So everything is eventually being hurt by this process, and we end up with geographic atrophy with a missing cell. So this takes forever here, but eventually that RPE cell is going to have died, and that's the pathophysiology of dry AMD going to geographic atrophy. So patients always tell me, do I have the good type or the bad type? And I say, neither of them are the good type. And that's the unfortunate. I say, and I borrowed this from another speaker, I think of macular degeneration like a big oak tree with two different branches. There's the dry geographic atrophy branch, and there's the wet, I'm going to need lots of injections for wet AMD branch. And patients can hop back and forth between both those branches, but neither branch is good. We'd rather you not be on that tree at all. We can't fix that yet, but neither branch is the good type because they both can progress. And I'll show that a little bit more too. So here's a patient with geographic atrophy developing, so lots of drusen, but then the geographic atrophy starting now in the center of the fovea. And this patient now would be 2400, but they were dry the whole time. So that's why dry is not the good type. It still can advance to geographic atrophy. So I'm gonna go into some research updates. We'll first tackle dry AMD and geographic atrophy, which I'm really glad to be giving this talk now, because if I gave this talk even 5 years ago, I'd have way less to say. It's been a really booming field, and I also realize that what I say now is not going to be what I say in 5 years from now, because we have tons of updates and trials going on in this field right now. But it's been a challenging disease, and the retina specialists have been very challenged by this disease because they still don't fully understand the entire pathophysiology, the entire genetic background of this disease. We actually still don't have a great in vitro model or reliable animal models. You know, it's a very, and the surrogate for human studies we're working on with imaging, so we are getting pretty good at imaging, but it's a challenging disease. So we know, here's what we do know. The molecular basis for emerging treatments. We know it's linked to oxidative damage. We know that AREDS vitamins help. Lipofuscin is part of the process of debris and buildup of abnormal material. And we know that the visual cycle is involved with vitamin A metabolism. We know that chronic inflammation is at play. So the eye, when it starts to degenerate, becomes inflamed with itself. But it's chicken or the egg, did the inflammation cause it or did the degeneration cause the inflammation? Probably the degeneration caused the inflammation. And a lot of these studies treat the inflammation and treat with the complement system, but you can see what I'm saying, they don't necessarily treat the root cause of the disease, which we still don't fully understand. So sometimes we're trying to treat the egg and not the chicken, or vice versa, and it can be problematic, and we really need to completely cure aging and cure and reverse aging to be able to fix some of these things fully. But in the meantime, since we can't do that, we don't have a fountain of youth immediately at our disposal, we can do really smart and innovative things to treat all the different sequelae that are happening and get the eye to stabilize as much as possible. Okay, so that's really the big cycle that's going on. So there's been a ton of trials. First, we just lasered drusen, not the fancy laser we're going to talk about today, but we just blew away at drusen. That didn't work. It just caused blind spots. We tried the ciliary neurotrophic factor. Didn't really work. Didn't have efficacy. That was an implant in the eye that was a neurotrophic factor, but it didn't have efficacy. Fenretinide is a visual cycle. Let's just slow down the visual cycle and make the patient not see. Well, that didn't work because it had dark adaptation delay and night blindness. Didn't really work. AREDS, that worked, so we have some help here with the AREDS. And then the complement inhibitors, yes, we have 2 FDA approval in the complement inhibitor pathway. Stem cell therapy, nothing FDA approved yet, but some interesting trials underway. And even in my clinic, a gene therapy trial for dry AMD right now, which is using a complement inhibitor. So those are those vitamins for AREDS 1. AREDS 2, they change a little bit and drop out the vitamin A, which is beta carotene. So that's what we reduced there. And the case for complement and inflammation. So if complement, think inflammation. The complement pathway is part of the immune response. And we have a classic immune and a classic immune response that it's part of, and this is an example of what a huge area of geographic atrophy, what you see here are the underlying whitened choriocapillaris vessels because they've also died. So a lot of central loss of cell and underlying blood vessel pathology here. And we know a little bit about genetics as well. Uh-oh, I didn't mean to go right through that. So these are some of the complement inhibitor trials. Many of them have failed, and now we have 2 that have not failed. So, but these trials are, for instance, the lampalizumab trial previously failed. This anti-CD3 didn't make it far. But we do have here the apellis drug, and lampalizumab failed. And then the Zymora, so that is an anti-C3, for those who want to know about complement inhibitor pathways. And the other drug that's approved is an anti-C5, part of the complement monoclonal antibody. So, and this is the company, Astellas now that acquired the product. So the lampalizumab was, everybody was so excited about this. The Mahalo study, phase 2, lampalizumab did great, and then their phase 3 failed. So that just tanked, that didn't go anywhere, and that happened years ago. It was just devastating to the field of retina and to patients because the data in the phase 2 looks so good. But this happens not infrequently that things fail in a phase 3. But 2 drugs made it through a phase 3, Syfovre and Izervay. I feel like I keep saying that. But Syfovre, and these are the data. So the Oaks and the Derby were the 2 studies. I know you can't see this, but just look at the numbers here. So 18%, 17% reduction. What they're measuring is autofluorescence atrophy growth. So we measure with the fancy reading center how quickly is that autofluorescence black area growing. And then we had patients on placebo getting nothing, and patients are sham control, which means they don't get anything put in the eye, and then patients getting the drug. And it's either an every monthly drug or an every other month injection. And the patients that were on drug progressed less rapidly. So it slowed. Now notice that didn't go flat. It didn't stop their progression. It just slowed it by 18 to 20%. You could ask, is that worth it for me doing shots in my eyes every month or every other month for the rest of my life to have an 18% reduction with the risk of 1 out of 2,000 infection, or is, a small risk of occlusive vasculitis where you go no light perception. So there are risks, and that's the important point of discussing all these things with your patient. But ultimately, you and your doctor need to make that risk-benefit discussion. Depends on what your lesion looks like, depends on how risky your progression pattern. So it really depends on your eye, and you'll have that conversation, that consent conversation with your doctor, and ask lots of questions when you have that conversation, because it's very different for every patient. So I cannot counsel at all whether or not you should be on this drug or not. I have to see all your images, and we have to have a 30-minute conversation, me and you, or your retina doctor. So then the Izervay, let's just skip that. So the Izervay did 2 studies, Gather 1 and Gather 2. Very different data, same drug, different populations. 35% reduction versus sham, 17% reduction versus sham. Which is correct? I don't know. I mean, that just makes you understand the variability with some of these data, even these 1,000-patient trials that are big global trials. So in any event, the FDA approved it. So both those drugs got approved. Can you laser AMD? Yes. The Lumathera Valida light delivery system was recently FDA approved for dry AMD, as in this calendar year. So I didn't even know if they were going to be a sponsor. I have no relationships whatsoever for that company or any of these things, but I think their information is here today, but I'm just trying to be comprehensive and cover everything. I don't have this laser at my clinic yet, maybe we will in the future, but it's very new. But what it does is it uses photobiomodulation, or a very fancy light therapy, multiple treatment sessions, and they can be long and intensive, but if it gets rid of a drusen and prevents you from getting geographic atrophy, that can be pretty amazing. So we'll have to see how this plays out. This has not really played out yet in the commercial world because it's so recent. This laser is, has to be bought by a practice and be able to be billed to insurance, all these little logistics of how things roll out when something's FDA approved. It doesn't just immediately appear in a doctor's clinic and I can use it the next day. I wish it was like that. I'll take it if someone wants to give me this laser. But it is hopefully going to be rolling out, and we'll see more commercial data from this, but the trial data did get it FDA approved. Genetics, I want to just, at least as a geneticist and a hereditary disease specialist, say one thing, that this is not a straightforward monogenetic disease. I have patients with Stargardt disease. I have patients with retinitis pigmentosa. Those are monogenetic diseases. They can be dominantly inherited from a parent or recessively inherited, and it's passing down through the family with the gene. AMD is not that, so write that down. AMD is a multifactorial disease with multiple different risk factors, age being number 1, smoking being number 2, and then genetics being a very confusing number 3, and we don't fully understand it. But we know some of the genes that predispose, so meaning multiple genes can predispose, multiple genes can protect. It's not like the AMD gene. But so these are some of the genes that predispose, complement factor H mutations, the HITRA ARMS2, even lipase C and TIMP3. These can be predisposing gene mutations. Should we do genetic testing for AMD? I get this question constantly, but the answer is still sort of ambiguous. I wouldn't say definitely yes or definitely no. The Academy of Ophthalmology, this updates every now and then, but at least recently, Ed Stone was still saying genetic testing is very useful from a research standpoint, but commercially it's still questionable whether the clinical data warrants the genetic testing yet for the population. But there's some interesting controversy here. This is an evolving field. Zinc may be harmful if patients have 2 complement factor H risk factor alleles, which is pretty rare. But the question is, should we do genetic testing on everybody to rule that out before we just put you on AREDS2, which has zinc? So, I still haven't, I think it's hard for me to engage a really controversial topic. Genetic testing can be expensive. We don't have commercial insurance coverage sometimes. So anyway, I'll just say that it is a possibility to get genetic testing, but it's not widely clinically applicable or necessarily covered by insurance yet. Gene therapy for GA, so intravitreal injections. We did this trial at my site, Janssen, Parasol trial phase 2. This is an intravitreal CD59 soluble inhibitor, and so we don't have data on this yet, but their phase 1 data had some promising data slowing down geographic atrophy and being safe. So it's a single shot in the eye of a complement type drug that might slow geographic atrophy progression. The nice thing about gene therapy versus these other drugs is that gene therapy is a one-time sustained treatment. So they got their 1 gene therapy and then we watched them for the 2 years of the trial. It can be more inflammatory because gene therapy can cause inflammation, so we have to watch and put them on steroids, usually topical steroids, but that's something to consider. The Sanofi is starting, actually we're starting this up right now, a phase 1/2 gene therapy trial for dry AMD, geographic atrophy. The inclusion criteria of this trial do allow foveal involving geographic atrophy, so you can already have loss, so even the bad eye can be treated, and that's just important because some of these trials only allow patients who have not lost their central vision yet, but we still have a goal to keep the atrophy as small as we can. And anyway, it's a dual targeted C1 inhibitor and a BB inhibitor in the alternative pathway. And then I was a surgical site and did these surgeries. This is a subretinal injection, a company called Gyroscope, which got acquired by Novartis. Patients went to the operating room. I did the surgery. Operating room, subretinal injection, so meaning a touchdown with a cannula and raise a bleb of a complement inhibitor. It's called CFI or CFI protein, which actually inhibits complement. That's what CFI does. And patients were followed, for the 2-year duration of the trial, and then they're followed now in a long-term study. So I still see these patients in long-term follow-up for 5 years. The study was unfortunately terminated because they didn't see the efficacy signal that they were looking for. So that was a subretinal injection. So that, not everything works. This is why we do these phase 1s and 2s, and this was a more invasive trial than some trials because it was a trip to the operating room and a subretinal injection. Stem cell therapy, I'm not going to talk about too much, but a company, Astellas, interestingly, which we mentioned with Syfovre, was previously Okada Therapeutics, has been for years working on AMD, and let me see if I can show you kind of what they do. So stem cell therapy is Dr. Lanza's work, and there's different things we mean by stem cell therapy, but basically what most of these trials were doing were taking stem cell derived RPE cells, so actually getting the stem cell to differentiate into an RPE cell and then injecting that subretinally. So this importantly wasn't, you can't just squirt it in the eye or put a drop on the eye. It's a trip to the operating room, subretinal injection, and this trial has gone on at many sites. This is just a photo of that surgery happening, Steve Schwartz at UCLA. And these have to be very carefully, perfectly managed. These are cells, so the temperature has to be correct, and the pharmacy has to be able to ship them, and they ship on the day of surgery, and all this exciting stuff happens. Importantly, just to be realistic here, these are risky surgeries. We're doing a surgery, we're injecting stem cells, the stem cells might fail. We have to suppress the immune system of the patient, so they're on the equivalent of a chemo, milder. You're not going to necessarily lose your hair and have a significant side effect from it, but some of these drugs are tacrolimus, Cytoxan, cyclosporin, significant drugs for the first several months to just really suppress the immune system. And that can be dangerous in a patient, any patient, but certainly a patient over 65, that can be dangerous. And so, and every protocol is different. But it's important to think about the risks, and I think as a physician, one of my primary goals is to do no harm. So I spend a lot of time in informed consent conversations, especially for surgical trials, thinking about, is this good for you? Switching gears, we're going to now talk a little bit about updates in the wet AMD field. Can I have a time check? What time is it?
You got like 8 minutes for this.
Okay, good. So we're going to go through wet AMD updates. Again, I said we were living in the anti-VEGF era, but what did we do before that? Well, we just obliterated the retina. We would laser it, and we'd say, yay, we won, and we have a massive blind spot in the retina, but the membrane wasn't bleeding. And then we did a little fancier laser called PDT, but we learned about 20 years ago, actually, that we could inject a drug into the eye and stop the CNV process, but also not obliterate the vision and keep the vision, actually improve the vision. So it was a huge landscape paradigm change that we actually could improve vision when we start therapy with these anti-VEGF drugs. So these came along, Lucentis, Avastin, Eylea, some of the new ones, Vabysmo, HD Eylea. And so this is what a CNV looks like, the damage caused by RP and photoreceptors. We would just obliterate it with laser. This actually, let's see, I did my fellowship in 2011. In 2011, we were no longer lasering membranes. So this is just the timing of kind of how old this is. So we don't really do this anymore, lasering a membrane. Thermal laser, and this was the study that showed kind of basically you'd obliterate the membrane, and here's they're gonna laser this big membrane, watch it turn white, and then it's gonna turn to a massive scar, and that scar is gonna go right into the fovea, and that patient's gonna end up 2400. So, but stop bleeding, but that's how we used to deal with that. So lots of, and also would recur and leak, and patients would have vision loss. And then we tried this PDT laser, which worked a little bit better, didn't scar quite as much, but the patients never gained vision. So PDT laser, I still very rarely do if it's an extrafoveal lesion, the patient can't come in or they're sickly or some other problem. We sometimes will use PDT laser to quiet a membrane. But now we're in the anti-VEGF category, and so lots of cool trials have helped us get here. So ranibizumab Lucentis was the first FDA-approved treatment. This was really the big game changer. Here's that showing you an intravitreal injection. This is a monoclonal human antibody that basically temporarily shuts down the process of neovascularization. And so these are the patients that had, I mean, this was the cool stuff when they showed us at retina conferences, how many years ago this was. I remember like literally got a standing ovation at Academy of Ophthalmology because it was just such a game changer. We finally, once you start treatment with Lucentis, we had vision improvement, 10-letter vision improvement. And then versus the sham, who were getting nothing, because that really was the standard then. We didn't have a way to treat it, that they just did terribly. They lost 15 letters. And this is where we compared it to PDT, because then whatever the standard of care is, that's what the FDA wants you to compare your trial to. So then when Anchor came along, they compared Lucentis to PDT. Look at the difference, 10-letter gain, 10-letter loss. Which do you want? So this was just incredible to really game change the field here. And now we have all of these other injections, so tons of companies have said, this might be a really good field for me to do a trial in and get a longer acting drug. And so that's what we've been dealing with now in the last 20 years is newer drugs, better drugs. And these are some of the adverse events. There's always adverse events, infection, things like that. Avastin, and then we actually do have, Avastin was not specifically studied by a company. It's actually, we knew about it from colon cancer. We used that molecule in the eye. Phil Rosenfeld at Avastin injected that in the human eye without an FDA trial for that. But now the CAT trial actually looked and compared Avastin and Lucentis head-to-head and showed them to be equally safe and effective. So because of that, now insurance companies often require step therapy and have you have Avastin first before you can get the other drugs. But Avastin and Lucentis are basically the equivalent. But we do now have, how long does this step through go? It's stopped advancing me. Okay, so I'm just gonna skip through because I wanna get to gene therapy here. This is Eylea. This is a bigger kind of different molecule. We call it VEGF trap, and it's just a different molecule. We think it probably lasts longer from data than Lucentis and Avastin. And this is, if anyone's on Eylea, what the Eylea molecule looks like. So it had excellent data, the VIEW 1-2 trial, so just massive amount of work and time and patients treated here to show good data that this lasts about 8 weeks in the eye. And then these new longer acting drugs, Vabysmo and HD Eylea. Vabysmo, this take-home points here, approved for a 16-week interval. Does not mean it always lasts 16 weeks. It means in naive patients who were just cream of the crop, picked, perfect inclusion criteria, that some of them were able to meet a 16-week interval. When I have my patients who are struggling on a 6-week interval Eylea, and I switch them, we often don't get a 16-week interval. We might get an extra week or two, but we do whatever we need to do. We look at the OCT each visit and see what the patients need. So, what I want to just do before this is a cool thing called a Susvimo implant. This is a little surgical implant, and your doctor can instead, I don't do this, this is sort of not that commonly done, but it is an FDA-approved little implant where you can inject your little port as opposed to injecting directly in your eye. There's some risk to this, and you end up with a little scar. You still get injections, but the Susvimo, theoretically, you can re-inject it every 6 months in the clinic after you've had your surgery to get the implant in. So last thing here, before we go to questions, gene therapy studies. We've had several, Genzyme, Oxford Biomedica. Regenix Bio was a surgical trial. I did this trial on SoulSight for this trial. Atmosphere and Ascent are in phase 3, which means they showed efficacy in phase 1. And that is a trip to the operating room, a subretinal injection of a drug similar to similar to Lucentis. And we have probably good safety and efficacy data that we're getting from these. Not FDA approved yet, so importantly, we don't have that final data yet. And then 2 intravitreal phase 3 trials. We were Sight for 4D's phase 1. At that point, they were recruiting patients who were end-stage, difficult, low vision. Just to show you the landscape, these 2 trials are only recruiting naive patients. So if you've never had an injection in your eye, we're having that conversation on day 1. Mrs. Jones, you have wet AMD. I'm going to tell you a little bit about that disease. And by the way, do you want to sign up for a gene therapy trial to treat your eye? Because that's sort of where the landscape has evolved to and how commonplace. We don't have an FDA approved yet, but that's a single one-time injection that delivers an AAV. So we're adding a growth factor. So we're not curing the AMD gene. Again, there's no AMD gene, but instead we're delivering either Eylea, Lucentis, whatever the molecule is we want to deliver. We're injecting it intravitreal. That's just a normal shot in the clinic, and then it sets up the eye as a biofactory. Here's an example of a subretinal injection, but sets up the eye as a biofactory to secrete that protein chronically. And so the idea, we don't know if it works yet, but the idea is a one-time shot, and then we follow those patients. We still see them every month, and we see if they need a supplemental injection. But I've had many patients who've made it through their first year of a 4D trial, the 4D therapeutics, and not needed a supplemental injection, where they used to be getting monthly injections prior to that. So it's pretty amazing, and the field is really changing. So there's a lot of hope and optimism in this field that we're trying to get some better drugs and longer acting drugs, and research is really innovatively dealing with this disease. It's a very visually devastating disease. So in conclusion, dry AMD take-home points. We know that AREDS slows progression, so take your vitamins as long as it's safe. We can talk a little bit about laser to drusen, that laser machine. We're all kind of thinking and looking at that over the next few years. That may be something to follow and think about. 2 FDA-approved drugs. Talk to your doctor. It's really specific to you, whether or not you'd be a good candidate. And there are some gene therapy trials for dry AMD, for geographic atrophy. And then, again, switching gears, exudative AMD, multiple intravitreal injections. We have a ton of options of what drugs to use for you now. Some of them can last up to 4 months, sometimes in some patients. And we also have gene therapy trials with the potential, either subretinal or intravitreal, single injection that might be able to sustain the eye and set it up as a biofactory to not need as many injections over life. And that would be a wonderful thing for most of my patients. So my advice, follow your AMSOR grid, see your ophthalmologist, take your eye vitamins. Don't smoke. Number 2, for wet AMD, make sure you're routinely following your retina specialist. Try not to miss appointments, reschedule quickly if you have to miss. We don't want you to have a subretinal hemorrhage if you miss an injection. Chronic disease, don't smoke. And ask about trials. There's a lot going on now with trials and new therapies and treatments, so it's definitely a very actively growing field. Okay, with that, I will open up to questions if we still have a minute for questions. Yes,
please raise your hands and I'll come up with the microphone. Just a minute. Who was up first? I'm coming. Because it's a
Hi, I have drusen, and I was wondering, I know you mentioned how they can sort of look at that and there are different degrees of having drusen. Do I need my retina specialist to let me know how severe mine is? Is that something that there's no predicting from where I am now to what may be? And I do have the genetic component with my mom, so I'm just curious.
Okay. Yes, and not at every visit, not all retina specialists will go through that AREDS risk severity score scale, but you can certainly ask, and we can look at that at an appointment. What we're doing is just gauging the number of drusen and the number of, whether or not you meet a certain score scale. So you saw that graph where it's basically, if you're at the worst, if you score a 4, you might have a 50% chance of converting either to geographic atrophy or wet AMD, those two branches of the oak trees, in a 5-year period. So it's worth asking, we don't always necessarily every visit focus on that, but certainly worth a question. And then you said the genetics, that was in your family.
Right.
Mm-hmm. Yeah.
So it's like a score you get based on different.
Yes, but I would say probably, I don't know if I give talks on this and I occasionally give that score to a patient, but I don't necessarily always do that. I don't always write in a clinic note. A lot of ophthalmologists, retina specialists don't. We just say, are you good or are you not good on a given visit? It depends on how much we communicate. So always ask, if you're wanting a question, definitely specifically ask your retina doctor to answer that question.
Thank you for this overview. This is fantastic what you've given us, all the information. I have a question regarding gene therapy. You said that only naive patients are used for gene therapy. Why is that?
Okay, yeah, let me definitely explain that. So for any given trial, there's inclusion criteria and exclusion criteria and a recruitment goal from the given protocol. Now, gene therapy, if it works, would work on anything. So it's not that and the phase 1 trials, so when a drug first comes out, they're going to recruit, the company who writes these protocols, because we as the investigators don't write these protocols, the company is going to recruit end-stage patients with lower vision. They're at that point really evaluating safety, so they don't want a patient with 20/20 vision, they don't want a patient who just started injections. So for the phase 1/2s, we treated, all of our patients were not naive, they were previously treated patients. And 4D Therapeutics, the first patients treated were very aggressive, we call them frequent flyers. They're my patients who come in every 4 weeks, and sometimes I even bring them in for a Q2 week of Aston in between, because they just so they're very active patients. Now, and every company gets to write their own criteria, because with the FDA, they worked out their primary endpoint for most of these trials. It gets very complicated, but basically it's because their primary endpoint is going to be what most AMD trials do, is a visual acuity gain after starting treatment. And that's going to be a primary endpoint to get a drug approved or not with the FDA. The trial criteria are going to select, this is a common disease and they can do that, they can select patients who are naive to treatment. So when you come in that first day, your vision might be 2200 because you have an active lesion right in your fovea. When we treat them, we see improvement of vision. And so that honestly is the real reason why companies are looking for that naive patient population, because they need to get an FDA approval to see a visual improvement. If you already have a stabilized patient who's doing well, you're not going to see a change. So it's not that the drug wouldn't work. And then there are some trials that will have cohort 1 and cohort 2 and filling 2 cohorts. Lots of companies do this. My diabetes trials, I do a lot of iBio diabetic trials, will have cohorts that are naive or not naive. And a new therapy when it comes out might be looking at non-naive patients. So I wouldn't say that just because you have been getting injections, you might not be candidate to another gene therapy trial. Companies are always coming out with these new gene therapy products. These are just the 2 phase 3 that are currently enrolling that I mentioned just now.
Okay, can you hear me?
Yes.
Actually, I don't need it. Regarding the GA, does it deal directly with central vision, or can it kind of, you get distorted vision maybe to one side so you can still see straight ahead but miss something on the side, or is it always central?
Yeah, interestingly, GA normally begins extrafoveally, so not centrally. Not in all patients, everybody can be different. Every eye can be different, but I'd say the majority of the time we see drusen coalesce into a geographic non-foveal, non-central spot. And the patient's going to notice distortion depending how good of an observer they are in that eye. And the point where they lose central visual acuity is when it's traveled into the center.
Thank you.
2 quick questions. If you have wet, what are the chances it turns into dry, or vice versa? And if you only have one in one eye, what are the chances it'll migrate to the side?
Yeah, that's the confusing question of my oak tree analogy. So that having dry does not protect you from having wet. You can have them both simultaneously. Now, maybe the best way to explain this is that we actually have a lot of patients who have geographic atrophy. And when we talk about, I think what you're asking there is geographic atrophy, so the advanced form of dry. If you have wet AMD or a neovascular membrane, you're getting injections for that. You may also have a growing geographic atrophy lesion, which is that advanced form of dry, in the same eye simultaneously. And some patients, and I don't do this, but some doctors will inject both eyes on the same day with the Syfovre drug and then their wet AMD drug. I don't do that. Some doctors will be treating them in stagger. So some patients are getting injections for both geographic atrophy and wet AMD because they don't do the same thing. So you're not covered. It's a very different molecule that we're injecting. So maybe that answers the question. And then we have to stagger visits, and you can have both advanced forms of disease in the same eye.
What about moving from one?
It's not so much that it moves from eye to eye, and eyes don't always behave symmetrically, so I have lots of patients that have wet AMD in one eye and the other eye only has a few drusen, and I don't even fully understand that myself. There must be some difference in blood flow because there's not a difference in genetics. It's the same person, right? So and the person either smoked or not, and they're the same age. So there must be some underlying things that we don't fully understand about the setup of the eye itself. But I have several patients that have just a few drusen and the other eye has a pretty big neovascular membrane. So the more important thing is, what does the eye that we're talking about look like, and what's that risk look like on imaging? Not so much what the other eye looks like.
It's an elementary question. I think part of it you just answered. Do they always come in twins? Do you get macular degeneration in both eyes, or can you have it in just one eye?
Are you meaning twins like in people, in humans twins?
No, I mean two
Oh.
eyes. You said you can get wet in one and dry in the other.
Yes,
Can you get just one eye with MD
yes.
and nothing on the other?
You basically can have all combinations because each eye is going to independently do what it wants to do. And again, one eye might have both geographic atrophy and wet AMD. The other eye, weirdly could have really just a few drusen and neither. So there's all possible combinations of very complex disease. And the asymmetry is something that's very interesting. Generally speaking, eyes are going to be more symmetric than not, but I always have a lot of outlier patients that have an asymmetric disease involvement.
Okay, we only have a
You want
few
to have
more
one? Okay.
questions to answer.
He's got one up here. He's been
Okay.
patiently waiting. So, you want to just shout it out? Or she's coming. She's coming.
I have two questions. Is there a special eye drop that people can use with macula? Because, the dry eye, they have a whole range of dry eye medication lubricants. Is there some
Oh, is there a special eye drop format? No, unfortunately, I'll never say never because I'll be wrong in 10 years hopefully. But at the moment, there's no FDA-approved topical drop for this disease. There are still studies, even now, you can find studies with topical drops for any disease, including macular degeneration. Whether or not that could really penetrate, most of our pathophysiology data would make it very difficult for me to understand how a topical drop is going to penetrate, because we need to treat the RPE photoreceptors, we need to get drug in there. But I'll never say never. Maybe somebody could formulate something. But for a patient, if you're asking just what drops should you use, we just want your eyes to be healthy and well lubricated. And so that's why I hesitate to use the words dry and wet. And here, talking about the cornea, let's just say well lubricated. So we want your eye to be well lubricated with whatever, refresh, sustain, whatever topical tears you need to keep healthy corneas.
The other question is, AREDS2 the only vitamin available?
There's lots of permutations of that, and you'll see, even at your eye doctors, we don't do this, but some clinics and optometry clinics will sell and have different products and with slight differences. We just generally, the only data we have is the AREDS1 and AREDS2 huge big trials, and so you want, at a minimum, your vitamins to be those. And if they throw a couple other things in there, go over with your eye doctor if they think those are okay. They might have put in another antioxidant, but you want to make sure that your AREDS2 formulation vitamins are in whatever vitamin you're using.
Dr. K, there's a question. If the membrane is peeling, will it prevent MD?
If the membrane is peeled,
Peeling.
I'm not sure if we're talking about membrane. So there's something called an epiretinal membrane peel, which is a surgery we do when a patient has an epiretinal membrane, which is an age-related glial cell proliferation on the surface of the retina. We take those patients to the OR and we peel that little fibrous tissue off the surface. That unfortunately does not protect that patient from macular degeneration. Macular degeneration, this is where I was saying this, the word membrane is really confusing. We use it too much in this field, but we're talking about a choroidal neovascular membrane, which is a blood vessel membrane under the retina. And so no, we can't go in and cut that out or peel that out because it's inside the eye. It's inside the bottom layers of the blood vessel part. Thank you for the question.
All right, I want to thank you so much, Dr. K, for coming today and giving us this information.
Hello, my name is Hannah McArdle. I'm here with Dawn Solomon, and we're with the Division of Blind Services. And I'm just going to tell you a little bit about our agency. The Division of Blind Services is a state agency, so we are in, all Florida counties, all cities in the state of Florida, and there's, actually blind services is nationwide and different, each state has their own vocational rehab agency. So because we are a state agency, nonprofit government agency, all of our services are free of charge, so they don't cost a thing. And we have several programs. The primary purpose of our services is to assist people with adapting to vision loss so that they can live productive and independent lives, whatever that may look like for them. So we serve from babies all the way to elderly. So, from birth to earth, so to speak, So, yeah, and so our blind babies and our children's programs, all about kind of helping people get prepared, helping our youngsters get prepared for life after school and adapting to that vision loss early on. And then we have our vocational rehabilitation program, and that is for adults that want to work, that are visually impaired, that are interested in employment and want to pursue employment. I will share with you, I was a client at one point of Division of Blind Services myself. It's an amazing agency, and so, for the vocational program, we're assisting with accommodations, accommodating people's vision loss, maybe purchasing equipment, devices, magnification so that they can continue working. We help them find jobs, we can sponsor college, and we also, so in the vocational rehab program, we assist with eye medical services. So if you're working, even if you're working part-time, anybody here, if someone is needing cataract surgery, any type of eye medical surgery to maintain that employment, and they do not have insurance, that is something the agency is able to sponsor, is able to assist with. The person must be pursuing employment for the eye medical services. However, just so you know, that is something available. And so that's kind of the vocational program. It's available to anyone 18 and up. We have our transition program, which is from ages 14 to 18, and then, prior to that is our children's. And then, so after our vocational rehab program, like I said, kind of 18 and up, we have our independent living and older blind program. And some of these programs overlap, so I apologize for the confusion. We also have our adult blind program, which is ages 18 and up for individuals who do not want to work, and they want to, live their life. So in the independent living program, that's again all about living independently with vision loss. So maybe you're struggling with macular degeneration or diabetic retinopathy, and you're starting to lose your vision, and it's starting to get difficult doing those daily tasks, right? Cooking, cleaning, you're not able to see, when something is fully cooked, or, you're making messes, or you're hurting yourself, you're falling over steps, and it's starting to get scary. That's when you call us, okay? That's when you call us and we come in and we can provide blindness skills training. We partner with some amazing organizations. So our Gainesville office covers 8 or 9 counties, so don't quote me, but we cover about 8 or 9 counties, and that's Alachua, Bradford, Columbia, Gilchrist, Dixie, Levy, Union. This isn't in any specific order, but I believe Marion is the other county that we covered. And but again, if you're interested in our services, if you apply online and you put in your county, it will automatically route to the appropriate office. You can also just call our office and somebody can assist you over the phone with the application. If you have difficulty seeing and can't, do the application independently, we're happy to assist you with that. And so, our instructors will come in the home and work with you. There's 3 main areas of blindness skills training that we focus on, and those areas are orientation and mobility, which is learning how to use a white cane like what I have right here. Learning how to navigate independently and maintain that independence without, hurting yourself, tripping and falling. Also, it's really identification as well. It's letting other people know you have that vision impairment. And then we have training in independent living skills, or what we call activities of daily living, that cooking, cleaning, budgeting, money management, matching your clothing, like just grooming, doing your hair and your personal hygiene, makeup, all that good stuff is covered there. And then assistive technology, learning how to utilize like smartphones and some of the equipment like Bob Schrepfer is showing with the magnification company, learning how to utilize low vision devices to really maximize what you have. We want to maximize that usable vision. So with Division of Blind Services, our main goal is just to allow you to continue to live an independent, productive life. If anyone is interested, please reach out. Our services are completely free, as I mentioned. So we want to be there to help you reach your goals. So thanks.
Thank you so much. So please don't hesitate in contacting them if you need any of their services. We are now going to invite up Beverly Bennett from Elder Care of Alachua County. Alachua, sorry.
Hello, I'm Beverly, and I'm the manager of the Independence with Low Vision program, which is part of Elder Care of Alachua County. And as Hannah just mentioned, I am an orientation mobility specialist, certified vision rehab therapist, and I teach assistive technology. So when she was talking about all of the training that is funded by the Florida Division of Blind Services here in Alachua County for adults and primarily seniors, that is the training that we provide. And of course we partner with the Division of Blind Services, so they provide the funding, so the training that we provide is available at no charge. And then we're also able to help with some aids and devices that might go along with the training. So if the individual needed a handheld magnifier or a talking clock or a white cane, if tactile markings on your microwave or your washer, your dryer, any of those types of things, adaptive kitchen skills training. I teach people how to use their smartphones, their tablets, their computers. So basically, my table's in the back there. I've got large print phone numbers, or if you just Google Elder Care of Alachua County, if you call the main number, you can get put through to me. My name is Beverly, and I'd be happy to talk with you about that. Thank you.
All right, thank you so much. We are now going to invite up, where'd it go, Richard Pam, and he's going to talk to us from the company eSight. This is an exciting product. There we go. That you may be benefit from the use of, and I'm going to let him talk more about it.
Thanks, everyone. My name is Rick Pam, and I'm from eSight. eSight is an assistive technology device for people with central vision loss. So if you look up there, that's what somebody with central vision loss looks like when they see straight ahead. They have a huge blind spot. With the eSight device, in many cases, we can allow them to see like this. Okay, which is a huge difference. We enhance the vision that you still have. These are many different people that we help. We have kids as young as 7 to adults over 100 years of age that we have assisted in living their lives to their fullest potential. eSight was founded by an engineer in Ottawa, Canada, who had 2 sisters who had Stargardt's disease, which is a form of macular degeneration. In 2006, being an engineer, he started to work on something that would just help his sisters see better. It took him about 7 years, And in 2013, the first eSight product was launched. It was huge. You had to wear a shoulder harness around to hold the battery. Fast forward to today, the new eSight Go is much more glasses-like, much more powerful, and actually a third the cost of the original eSight device. Who can eSight help? Again, anybody with central vision loss that still has some peripheral vision, we can hopefully enhance the vision that you still have. These are some of the different diseases that we have helped. Macular degeneration, Stargardt's diabetic retinopathy, Leber's hereditary optic nerve damage. Again, any disease where you still have some peripheral vision, we can assist. So how does eSight work? eSight has a camera that's built into the glasses. The camera sends a real-time video image of what it sees, processes that image through some sophisticated algorithms, and presents it to two OLED screens in the glasses. And from there, you can do different things to those images. You can magnify, you can change contrast, you can do color filters, you can do a number of things, again, to hopefully help you enhance the vision you still have. eSight has done a number of studies, and actually we're in the process of doing them right now at the Brooks Rehabilitation Center in Jacksonville. But our earlier studies have proven 7 lines of enhanced vision, 100% mobility, contrast, all the things that you again need to do things in your everyday life. So the new eSight Go, as you can see here, is much smaller. It's only 170 grams, much more glasses-like, has increased battery life, 45 degrees field of view, and high definition, high resolution video imaging. So these are also just some of the other features that eSight has. I do have a table back there. I have the eSight device there for anybody that would like to try it. The nice thing about it, it's just a pair of glasses. You're going to put them on, you're either going to go wow, or you're going to go no. Doesn't help. But again, we've helped thousands of people over the 10 years that I've been with eSight. We have a 17-year-old that has Stargardt's disease. He's now in an orchestra, able to see the music and play. We have a number of people gone back to work. We have people who can see their grandchildren for the first time. Just many different things. So thank you very much.
Thank you so much, Richard. We now have the availability to see from Samsara Vision. We're going to talk to Jason Roberts, and he's going to talk to us about an exciting clinical trial that's going on right now for a revision to an existing product, but they got an update, so they're going to talk to us about that. So with my happy to introduce now Jason.
Good afternoon. Thank you so much for your time and attention today. Very glad to talk with you all. So I want to present an idea to you that may seem crazy. A telescope surgically implanted in the eye. That's what we're going to talk about for the next few minutes. So this is a Galilean-style telescope. It's called the SING IMT, or Smaller Incision Newer Generation Implantable Miniature Telescope. This literally is a telescope like what you would use to look at the stars, except it can help to bring back central vision for certain kinds of people. So there was a first generation, as mentioned, so that's on the left. On the right is the newer generation, and the newer generation is easier to implant for the surgeon. It helps vision to come into focus more quickly for patients, and is generally presented to be a better experience for patients. So this, between the first generation and second generation device, has had about 1,400 patients implanted in many countries, over 20 countries essentially. There's many peer-reviewed articles that have expressed what the clinical benefit is of this. Here's some examples of some of the data that's out there for the optics of this device. So when you think about when you're in the chair and your doctor's assessing what your vision is, and there are lines that they measure. So on average, this optic is shown to provide 3 lines of improvement. It can be as many as 6 lines of improvement, but every person's going to be different. So some won't quite meet those improvements, but that's the potential for this. What probably matters most is what my predecessor talked about, and that's activities of daily living. How does it impact somebody's life potentially? So if you look on the right-hand side, it talks about general vision, but it also talks about near activities, social functioning, dependency. One nice thing is that people can often recognize faces if they haven't been able to before. So again, the social component is quite big. Dependency, so the independence someone can have through a lot of the things they can do is huge, and these are the measurements of that. Mental health is another thing that it can potentially improve because it can bring you out of this place where you're dependent, you're kind of struggling with your vision and all the impacts that has. So as mentioned, this is actually a device that's approved in Europe. So it has the equivalence of FDA approval in Europe. Now we're working to have this FDA approved in the US. And there are actually close to 500 patients in Europe that have been implanted with this device. But you can see, many countries this is already available. So what does this do? This is probably very hard for people to see, realize that. But if you looked at me, and let's say, for example, if you could tell that I had a head, tell that I have hair, fortunately still, but you couldn't see my eyes, my mouth, expressions, those kinds of characteristics to recognize me, that's what this can change. So is somebody a threat? Is someone a family member? Are they friendly? Even before they say something, this may be able to help people to recognize that. So that's one of the main things. It can apply to other things, but usually that social connection is such a big thing. Realistically, self-care, watching TV, like I said, recognizing people's expressions and faces, various hobbies, reading large print. For small print, external magnification can be kind of used with this, so that would be required. Managing finances, things like that. What people can't do is drive a car, play tennis, see a golf ball and fight. Those aren't realistic expectations. We'd love for that to be, but it's not. So who is this for? That's kind of the big thing here. So this is macular degeneration specifically, nothing else. But people that are at least 65 years old, they have AMD where they have that scar, geographic atrophy, or they had the wet version, but now it's not wet anymore. That's where those patients typically are. They have to have at least 2160 vision, so that's pretty bad. So 2160, the worst it can be is 2800. So these are people with really bad vision with both eyes and blind spot in both eyes, essentially. They can have had cataract surgery in at least one eye. So those of you who have friends that don't have AMD, had cataract surgery, it was a new day the next day, colors are more vibrant, their vision's great. Well, we obviously know that's not the case for someone with advanced AMD. With this, essentially, this goes in the eye at the time of cataract surgery instead of an IOL, at least one eye. With that, there's some other requirements. Good peripheral vision is a key. The way that the vision works with this is one eye is for central vision. So think if you've ever used an external magnifier, like it can help with that vision. It makes an image bigger, it makes the blind spot smaller. You have a 20-degree field of view essentially for that eye. Most external magnifiers are more like 8%. So it's much, much broader field of view. With that, the other eye doesn't receive the device, and that has peripheral vision. So one eye, the telescope eye, is central vision. The fellow eye is peripheral vision only, for mobility, so you know where things are when you're on the move. So, as I'm finishing here, there's an external simulator. It's a telescope that's designed to simulate what the vision would be. In the back corner, I'm in the purple table. You almost can't miss it. I have that device. So if anybody wanted to simulate what their vision could be with this implanted device, that's what's used, as well as during the initial study screening. With that, it is in a clinical phase. Here's a list of all of the clinical sites. The key thing is one of these sites is in Sarasota, Florida. So there is one in Florida. Transportation is provided. It's kind of a white glove experience for the person who's the patient that could be enrolled. They pick you up at your home, bring you to the screening, to the surgery, to the visits, and then you get a helper essentially. So you get an occupational therapist who does vision rehabilitation with you if you were to be appropriate, or one of your friends or family members, because now you have images that are two different sizes, so that person helps you to adjust to that. Works with you for various exercises to maximize your vision and help you for about 2 to 3 months after surgery, actually. I have materials in the back if you have interest, brochures to learn more about it, and essentially the criteria as well as back there, but it's 2160 to 2000 vision, still no cataract surgery in one eye, bilateral AMD essentially. So with that, thank you very much for your time.
All right, thank you so much, Jason. So hopefully if someone qualifies to meet those stipulations, you will go back and visit. It is a really cool device with a lot of opportunities to help you see better if you qualify. So please don't sleep on that one. Go ahead and visit them and at least try out the external device to see if that's something. It's, I believe they call it monovision. Is that correct? So one eye for up close, one eye for distance type thing?
It's like that, except one eye is central vision and one eye is peripheral vision. Same concept.
Peripheral, yeah, okay. All right, we're now going to move on to the magnification company with Bob. He's going to talk a little bit about some low vision devices that may be able to help you in your low vision journey. Come on down, Bob.
Good afternoon. My name is Bob Schruepfer. I first would like to thank Donna and the Macular Degeneration Association for inviting me to this awesome venue again. I've been on tour with them for a few years. And so our company is the Magnification Company and Low Vision Technology Center. We are based out of St. Petersburg, Florida. That's the headquarters. And we have one of the state's largest showrooms of new technology that you would ever see. Of course, with that being said, what does that really mean? Well, we have two different types of business models. In my 38 years of helping people that are anywhere from visually impaired to totally blind, about 98% of the folks that we get referrals from, be it a low vision optometrist, an ophthalmologist, the Division of Blind Services, low vision occupational therapist, the VA hospitals. If anybody in here is a veteran, you need to see me because we help facilitate a lot of people getting devices and equipment that may be of value for your visual needs. But we carry over 400 different low vision and blindness devices that ultimately the goal is to keep you visually independent no matter what you're having challenges with. And those challenges, whether it's simply reading print off a medicine bottle, a book, a magazine, a box, reading signs on the wall, being able to recognize objects and your surroundings. There is a device in today's world of unbelievable technology that may be of value for you. So when we get a call from these different types of referral sources, there's not too many people that are going to drive from Gainesville all the way down to St. Petersburg, Florida. Do you know where St. Petersburg, Florida is? Yeah. It's 3 hours away, and I woke up at 4:30 this morning. But that's okay, I do it all the time. So we come to you, and we're kind of now, in the last year, one of one company that does not charge for an in-home assessment or evaluation. And so when we get the information from the referring source, and we do a pre-interview with you on the telephone of what you're having challenges with, then we can put together a pretty good arrangement
of devices where we're not bringing all 400 products into your living room, but we come to you and we do the assessment right then and there in your home. And you have no idea how effective that is, because whether it's something for reading, or with that reading being in your hands or fixed on your microwave or your oven or whatever it may be, or watching television or trying to magnify your computer, we can try these things out with you at no charge to you and no pre-investment, so you're not making a foolish cost without knowing exactly what the uses and limitations of the product can do. So there's now basically 3 divisions or 3 categories of low vision devices. And everybody at one time or another in their life, whether you were visually impaired or not, has used a magnifier. Typical over the counter, whether it's doing hobbies, crafts, getting out a splinter, reading a map, whatever it may be. So we carry a high array of magnifiers, typically from Germany, that magnify anywhere from 2.5 times up to 15 times. A lot of them are handheld, some of them are wearable, some come in telescopic formats. And then when people have unfortunately met their limit on what a magnifier can do, whether it's because of the field of view or the focal distance of how close they have to hold the device, then we go into the next category of what is known as electronic magnification. And electronic magnifiers actually are divided into 3 divisions. Handheld, portable, and all these electronic magnifiers, the big difference here is it incorporates a monitor and a camera. So whether they're handheld, tabletop, or wearables, you've got the technology of a camera and a monitor that actually eliminates all the distortion that a curvature of a lens would provide you, but it also gives you unlimited value on magnification. For example, if you're reading the small microprint on a medicine bottle or a recipe, and you've got a magnifier that magnifies 4, 5, or 6 times, you may be able to see normal size print with that, or sub-headline or headline, but when you get to that small microprint, you can't see it because the magnifier is 1 power. So when it comes to electronic magnification, with a push of a button or a turn of a dial, you can go from one range of magnification to another. And depending on product, they will magnify anywhere from 1 to 80 times magnification. And with that being said, you can also determine what type of contrast is best for your vision, whether it's black on white, white on black, black on yellow, true color, whatever it may be. So the options and the output of value for your visual independence is unlimited. And people do not know what they don't know. You know there's almost 5,000 eye care professionals in the state of Florida and less than 2% do anything with low vision? It's incredible. And most of the people that we see, we get them from the surrounding referring sources that is outside that umbrella, not because they don't know or they don't have time, it's just, it is what it is. So when we have these products and we bring them into your life, for some of you that may have been using these for a while or may have something of this kind, they have extended the technology and value. For example, there's a magnifier that's back in the back of the room here. It's called the Mirror Pad, M-I-R-R-O-R Pro. Has 2 cameras. One, you put your print or your book or your text underneath it, and it magnifies everything from near, whether it's reading or writing. Then you have a secondary camera. That camera can turn almost 360 degrees to magnify your face, to magnify things in the distance. And then in addition to that, you can push a button and it will take a picture of your print and it will convert it into speech. So you put a book, a document, your piece of mail, your bulletin, whatever it is, and it will take a picture of it, you can magnify it and sit back and have it read it to you aloud. Then last but not least, this brand new product back there, which is an amazing device, you can hook up now your Android or your Apple phone and turn your 5-inch phone into a 17-inch phone and magnify it unlimited, read all your emails, surf the internet, play games on it with a true plug and play, no computer knowledge or software integration at all. It just plug and plays right into your CCTV. It's absolutely amazing. So this is the world of video magnifiers, and as Rick explained with eSight, that's the 3rd category, is the wearables, and they're phenomenal because those give you the actual ability to be completely portable. So if we're looking at things in the distance and near, being hands-free with an unlimited amount of magnification is absolutely phenomenal. And it's worth taking a look at that. And so we come out to the home, and instead of a quick demo at a venue like this, we spend time and go over several different things that you want to try these with, indoor and outdoor, so you can truly make a decision. Even if you buy it, there is a return policy up to 21 days. Then last but not least, the world of text-to-speech, optical character recognition, and AI is starting to just go absolutely out of control for the better for everybody's visual independence. So I have around my neck right now a pair of Oakley Meta smart glasses. Has anybody heard about the Meta smart glasses? Raise your hand. 1, 2, 3, 4, 5, 6. Absolutely, and that's fantastic. What do they do? The Meta smart glasses came out a little over a year and a half ago. We were the first company in the state of Florida to take it from a retail product for the sighted population, which is what it's aimed for. As a matter of fact, as I was watching Sunday Night Football last night, they had 4 commercials on the Meta smart glasses on the football game, which I won, thanks. But anyway, in addition to that though, we took the product and we kind of wrote the manual in a workshop book on what the values are for the visually impaired to totally blind. Because there's a product here, and I'm only going to be able to describe so much because I have one hand holding a mic, that has a camera incorporated into the left side of the temple. There's 2 speakers in the temples over each ear. There's 5 microphones throughout the glasses. On a full charge, you have 8 hours of continuous use when you have this turned on, the little on and off button on the glasses. The charging case that comes with it is like any eyeglass case, only has a little conductor on it that you charge the case. The case recharges the glasses and gives you an additional 48 hours of continuous use. So you can basically use them on and on and on. So what's the big deal? The big deal is this. I can hold anything in my hand. I can look at the sign hanging from the ceiling in Publix and say, hey Meta, read what I'm looking at. It takes an instant photo of it and converts it to speech and tells me everything I want to know. It will read that whole menu so I know what aisle to go down to on Publix. It will read a book, a box. It will read handwriting. It will convert up to 15 languages to English and vice versa. It can describe this entire room to me for the most part. It will give me a definition of what's in front of me, a good amount of how many people are. I have a 3 to 5 second window to continue a dialogue with my Meta smart glasses. So for somebody that is severely visually impaired, legally blind, or totally blind, and you're looking down at the floor, and I say, hey Meta, what's on the floor in front of me? We'll say, and I did this, there are 2 dogs laying on the floor. These are my dogs. Then you got this window where you don't have to keep saying, hey Meta, hey Meta, hey Meta. Then I said, what color are they? And it says they are brown, black, and white, and they are. Then what really blew me away is I said, what is the breed? And it says they are a Beagle mix, and they are. They're a Beagle Chihuahua, by the way. They're called a Cheagle. Cutest things ever. So you can do this on numerous things. It can recognize currency. It can do great color recognition. And so if anyone is interested in these, same rule applies with all of our equipment. We come out, we give you a full overview. There's no charge. You try it out. You love it, great, you can buy it. If you don't, it doesn't cost you a thing. Now the price range on these, it doesn't matter. There's Ray-Ban has 3 frame styles and Oakley has 1. And it's not about which frame style or frame color you choose. If you get the Meta smart glasses with a clear lens or a polarized lens or a transition lens, which changes colors from dark to light, going indoors and out. There's no prescription that comes in these, but you can put your prescription in them after the fact if you want that extra value of a prescription. But the clear to polarized transition is now $400, $450, and $500. The price is amazing because prior to this coming out, if anybody's ever heard of the company called Orcam or Envision, they had similar products that range between $2,000 and $4,000. So this has been a life changer, not only what it can do, but the cost is so much more affordable. So I can't thank Donna enough and the whole organization for inviting me to help spread the gospel of our company, what we do. And this is just the tip of the iceberg. There's 9 devices, 10 devices I bring. to these types of events out of over 400 that we carry. So please, if anything, get our literature. If you're interested in an appointment, all you have to do is call or we can schedule that. Either me or one of my representatives is in or through Gainesville 1 to 2 days a week. Thank you all very much.
All right, thank you so much, Bob. The next thing we're going to do is do a quick video from Dr. Jennifer Jacobs. She's going to talk to us about the importance of early detection of AMD and about a device that you can use at home to know whether you've gone from wet to, or from dry to wet macular degeneration. So we're going to play that real quick and get right back to you.
Thank you so much for the introduction. The Nodal Vision Monitoring Center is proud to partner with the Macular Degeneration Association, and I appreciate the opportunity to speak to you all today. It is such a privilege to be able to do so. I would like to further discuss understanding the importance of detecting wet AMD early and how you can play a role in protecting your vision. 4C Home is FDA cleared and Medicare covered, and it is prescribed by your eye care professional when appropriate, depending on your level of vision and your stage of AMD. It is a form of personalized medicine with the 4C Home device used at home in between your regular eye exams. The device is a metamorphopsia detector, which just means that it detects visual distortions in AMD. AMD is a leading cause of severe central vision loss in people over the age of 50 years in the United States. I'm going to share with you the information you need to get informed and take charge of your vision. AMD is a chronic condition, meaning it does not resolve or go away, and it tends to progress or worsen over time. AMD progresses through 3 main stages: early, intermediate, and advanced stages. The advanced stage can be either advanced dry or wet AMD. Early and intermediate AMD are the slower changing, earlier form of the disease. However, once there's progression from the early to the intermediate stage, this puts one at risk for developing wet AMD. Not everyone with AMD progresses to wet AMD. However, those who do have a significant risk of vision loss, especially if not caught early. Wet AMD, which again is one of the advanced stages of the disease, can occur suddenly and without warning. AMD affects an area of the retina called the macula, which is responsible for detailed central vision used for activities like reading, driving, and seeing faces clearly. In the early and intermediate stages of dry AMD, changes occur in the cells of the macula and drusen, which are deposits built up in this area. These changes may induce blurry vision, such as difficulty seeing sharp details both up close and from a distance. Again, early and intermediate dry AMD are the slower forms of the disease, with changes you may not notice. Over time, the size and the number of the deposits in the macula can increase, which increases your risk of developing the more sight-threatening wet AMD. Intermediate dry AMD can suddenly change to wet AMD without advance notice. If you convert to wet AMD, abnormal blood vessels grow under and into the retina in the macula area. These blood vessels leak fluid and can sometimes bleed without any warning. You may not notice changes until significant vision loss has occurred. If you convert to wet AMD, significant vision loss can be rapid and severe. Symptoms of wet AMD include distortion, where straight lines begin to look wavy, dark spots or spots in the center of your vision, And generalized blurry vision can also be a symptom that patients may experience, as seen here on the screen. The good news is there are effective treatments for wet AMD. However, these treatments are most effective when administered early on, often before symptoms are noticed and vision loss has occurred. These treatments can halt or slow the progression of wet AMD, but cannot restore vision that has already been lost. Once the wet disease starts, it tends to continue to advance until you receive treatment. Irreversible damage can occur within days to weeks and often before symptoms are noticed. But how early is early detection? Once symptoms of visual impairment are noticed, like wavy lines or dark spots, vision loss may have already occurred. The earlier you catch wet AMD, the better chance you have of preserving your vision and your independence. So it is important to remember, wet AMD treatments are effective, but they are most effective when the disease is caught early. 4C Home is an early warning system for your eyes. You use this device at home in between your regular eye exams. It helps your doctor detect wet AMD often before visual changes have occurred. But how does it work? You take a simple daily test that checks for changes in your vision. The test takes a few minutes per eye per day. Data from each test is sent to your eye doctor as well as the Nodal Vision Monitoring Center, the provider of 4C Home. If a change in your test score is detected, the monitoring center alerts your doctor. Your doctor's office will determine the best course of action, which typically includes scheduling a follow-up visit. Testing with 4C Home is easy. Simply turn the device on and look into the viewfinder to begin testing. Take an easy test where a bump briefly appears and then disappears. Use the mouse provided to click where the bump appeared and then return to the center dot. Data from each test are sent to the Nodal Vision Monitoring Center for evaluation and also provided to your eye doctor. Regular at-home monitoring is like brushing your teeth. It's a good habit you do every day to help preserve vision. Our team will be sure to verify your insurance benefits and discuss those benefits with you prior to your acceptance of the device and getting started with the program. The Medicare-covered 4C Home is billed as a monthly service fee. There are low out-of-pocket costs for traditional Medicare patients, and depending on your coverage, you may pay nothing at all. If you do not have a secondary supplemental plan, you will pay around $15 per month after your Medicare fee-for-service deductible is met. 4C Home allows you to take a proactive approach to protect your vision. After the Nodal Vision Monitoring Center receives a referral from your doctor, we will answer any questions, verify coverage, and ship your device. Once you receive the device, the Nodal Vision Monitoring Center will walk you through setup and training. Once you begin testing, you and your doctor will continue to receive feedback from the Nodal Vision Monitoring Center. There are no obligations to enroll in the program, and you can cancel at any time. Managing your AMD with the 4C Home Monitoring Program can lead to significantly better outcomes. A major study showed that wet AMD is detected when the average vision is 20/83 in patients monitored using only standard of care, which means you wouldn't be able to see below the top 2 or 3 lines on a vision chart in your doctor's office. Numerous studies have shown that adding 4C Home to a doctor's standard care plan can help detect wet AMD while patients still have 20/40 or better vision. This is the vision required for unrestricted driving in many states. Hopefully I've given you some information on how you can take an active role in monitoring your eyes to give you the best visual outcome as you embark upon or continue your AMD journey. Thank you so much for your time today, and you may visit our website at orchome.com or scan the QR code on the screen. Thank you.
All right. Now, I'm going a little off script because we did end up going about 30 minutes early. So I'm going to give everybody a show of hands. Do you want to hear one more talk from our medical director about dry eye? If you do, we'll stay for 15 minutes longer, but I need at least a plurality of you to say yes. It's about dry eye, not dry macular. It's about dry eye. Yeah, I'd say we're to have a plurality. Okay, it's about 15 minutes. He's going to talk to us about dry eye and about the things you can do to treat it. So give us a few minutes and we'll get that started.
Hello, my name is Jeff Gerson, and I'm an optometrist and the medical director for the Macular Degeneration Association. I hope you're enjoying your seminar today, and I'm glad that I can present to you just a small part of it. The small part that I get to present to you today is about dry eyes. What is dry eye? And we're presenting this because over the last couple of years, we've had so many questions from people just like you, asking about dry eyes or talking about their eyes watering or asking, does dry eye have anything to do with macular degeneration? So that's why I wanted to present this to you today, and my hope is that you all learn something and enjoy it. So first, a few very basics. Number one, dry eye is not related to age-related macular degeneration. Dry eyes and dry AMD have nothing to do with each other. Now, some people with AMD have dry eyes, and vice versa, but they are by no means correlated with each other. Both, as it turns out, are more common as we age. Most of the time, dry eyes can be controlled, especially with the help of your eye care provider. Sometimes people just go out and buy artificial tears and guess and happen to pick one that works well, but usually it'll do better if you consult with your eye care provider on what you can do for your dry eyes, whether it be artificial tears that are over the counter, prescription medications, hygiene, or other things. And another very basic that's really important, not all artificial tears are the same. If you go to the store to go buy some, you will literally see dozens. Some are very similar or even maybe even the same to each other, and some are very different. So there will be something that will work well or better for you and others that won't. So defining dry eye disease. Dry eye disease is a multifactorial disease, meaning there's not just one thing that causes it or that we treat to try to cure or fix it. It is unstable or deficient tear film that causes discomfort and or visual changes. It is oftentimes accompanied by ocular surface changes and inflammation. That means inflammation in your eye and changes to the surface, the front surface to your cornea. Tear film stability is usually common in dry eye disease. That means that the functioning level of the tears in your eyes are not normal. And this can be measured by your eye doctor to help define the type of dry eyes that you have. Is it a matter of not enough tears or not the right quality of tears that you have? Dry eye disease is a continuum. So it can be very mild, or in some patients it can be very severe. And this level of either mild, severe, or anything in between can be either in the signs that your eye doctor sees or the symptoms that you as a patient are experiencing. Either way, there can be a fairly broad range. Dry eye disease can be anything from slightly annoying to, in some people, it's debilitating. It can be related to different systemic conditions or medications. It can be affected by the environment. So many times people's eyes are more dry during the winter time when it's dry outside or when they're not using a humidifier. And your eye doctor may use a formal questionnaire to help define dry eye, or just ask us a couple simple questions. I simply ask my patients, are your eyes ever dry, red, or irritated? To try to help prompt to know whether you're having symptoms. What are some of the causes of dry eyes? And you can see here on the screen, there are many different things, from contact lens wear, to heavy reading, digital device use, people that have had LASIK surgery. It can certainly be affected by diet or lack of nutrition, systemic diseases, problems with the glands that produce tears, environment. So you can see there's a whole host of different things that can cause dry eyes. So what are some of the symptoms? So probably the most common that I hear are that either someone's eyes are kind of gritty, they feel like there's something in it, or that people's eyes are watering. And I'll touch on that in a minute, why someone's eyes are watering, why that's actually dry eyes. But other symptoms you see listed here are discomfort or pain, a feeling of dryness, burning and stinging. I already mentioned the watery eyes. I already mentioned the gritty or foreign body sensation feeling in your eyes. Fluctuating vision is another very common symptom of dry eyes, especially if your vision gets blurry, you blink a couple times and it gets better. That's usually from dry eyes. Light sensitivity and redness. So these are all very common symptoms of having dry eyes. So what are some of the different tests that your doctor may do? Well, number one, they're likely to ask you questions. Some very simple, some may seem a little bit more in depth, but number one, asking questions. Your doctor will use a dye, a coloring dye, to look at the tears in your eyes, to see the quality of your tears and whether they're scratching to the surface of your eye. They may use a specific type of strip, a paper strip, to measure the amount of tears in your eyes. I know this sounds strange, but this is very commonly done in clinical trials and sometimes done just at regular doctor's visits to measure how much tearing your eyes are producing. There are devices that your doctor may use to measure the inflammation within or thickness of your tears. And your doctor may take photos of the glands that produce different components of the tears in your eyes. So the picture on the bottom, those are two different people with dye in their eye, and the one on the right is the one that has changes to the surface of the cornea, all the little speckles that you see, whereas on the left in A, it's just kind of an even coloration throughout the whole picture. So again, B in this example is the problem. So this is showing your tear breakup time, TBUT. So normally if you blink, it should take at least 10 seconds before your tears kind of start to break up. And if you look at the image on the left here, the video on the left, every time the person blinks, if you just wait a couple seconds, you see what you have there and the tears are breaking up. So normal tearing would be just that almost kind of yellowish green hue over the whole surface. And I'm going to restart the video here. So on the one on the left, you see the person blinks. 1 1,000, 2 1,000, 1 1,000, 2 1,000, 3 1,000. Within 3 seconds, those tears are breaking up. So the dark spots are the tears breaking up. Normally, it'd be more than 10. So if it's only 3 seconds, that means there's a problem with the quality of the tears. And therefore, your eyes will end up feeling dry regardless of the amount of tears you have in your eyes. But tears aren't so simple. So what we see here is just kind of almost like a little cartoon picture, and then some facts to the right depicting our tears. Our tears have over 1,500 proteins, the natural tears in your eyes. They have growth factors, they have different types of lipids, different types of mucins. So there are literally thousands of components to your normal tears. So that's why our tears are not so simple. So let's talk about tears. So let's go back to artificial tears. So these are over-the-counter products that you buy, usually in a bottle or sometimes in individual doses, to put in your eyes to hopefully help them feel better, be less dry. And as I mentioned at the beginning, number one, artificial tears that you buy at the store, they're not all the same. Please follow the advice of your doctor on what to use. Last year, there were dozens of products pulled from the market or that received warnings from the FDA due to problems that they saw in production. there are actually some foreign companies that manufacture tears that had bacteria in them and caused big enough problems that, yes, believe it or not, there were people that died from using artificial tears after having an eye infection that spread. So really important, listen to your doctor's advice on what products to use. There are differences in preservatives. Some have no preservatives. Some have additives to make your eyes white. Some are different consistencies. Please ask your eye care provider which tears you should be using. Because if you go to look at the store, it looks like this, and it's blurry. And it is a blurry picture, but I did it on purpose, because if you go to the store, you'll see shelves and shelves, dozens and dozens of different eye drops. And can you make sense of this? Probably not. You're not trained to or educated to. You shouldn't be able to, but your doctor can. Please ask your doctor what to do about your dry eyes. I've already alluded to this a couple times, quantity versus quality. Our eyes need both enough tears, but they also need to be of the right quality. So you may have plenty quantity, but poor quality. That may be why your eyes are watery. So there are specific products that help if your eyes don't have enough tears. There are specific products that help more if your tears aren't the right quality. So again, please ask your eye care provider to help you determine what's causing your dry eyes, what products should you use. Does diet and nutrition matter? You bet it does, absolutely. So that's something that we need to pay attention to. I know it's already been talked about in diabetes and in macular degeneration, but it also plays a big part in dry eye. So mostly the same good dietary principles that apply in AMD and in diabetes also apply with dry eye. And there are supplements that you can get just for dry eye. Historically, they were fish oil based, but there are some new ones that are not fish oil based that look like they can be very, very helpful. Again, ask your eye care provider. There are different in-office procedures or things that your doctor may do to help determine or to treat. The one on the left here is using a light, a specific way to look at the glands that produce oils in your tears to see if they're healthy. On the right-hand side are two different devices that are used to heat and express oils from those glands. Both of these look maybe a little bit like torture or barbaric, but they're both quite easy to perform and have performed on you. But both are in-office treatments for dry eye. So don't be surprised if your doctor talks about in-office procedures that, by the way, at least as of now, are generally not covered by insurance. So there are some procedures that can be done in the office that can be tremendously helpful. Another one that can be done in the office is what are called punctal plugs. These are little plugs that are basically put in the drains that your tears drain out of. So think of the sink in your kitchen. If water's running and you want to keep the bottom of the sink with a little bit of water, but you've got the drain wide open and there's never enough water to cover the bottom of the sink, well, maybe you put the plug in the drain. And that's what we're doing here. This is a very simple in-office procedure. Generally, it is covered by insurance. That can help keep the tears in your eyes longer. This works well for people that don't have enough tears, that have a quantity problem. It doesn't work well for people that have a quality problem. That's why your doctor will need to determine what's causing the dryness. Is it quantity or quality? This may be an option. There are prescription medications for dry eyes. Anything from a nose spray to multiple different prescription eye drops. And the idea of all these medications are to help your eyes produce more and better quality tears. So again, different types of eye drops, different modalities of treatment, but please do be aware there are prescription medications to help you when you have dry eyes. And they're not just to be reserved for when it's really bad. If people have tried artificial tears and they're not working or not working adequately, then we shouldn't wait before we have patients try or before you try a prescription product. Sometimes people's eyes will be very dry, and I'll talk about it, and they say, well, they don't feel dry, everything feels fine. Well, that's because someone may have a problem with their corneal sensitivity. So the example I would give is, if you have a gas stove top that's on and you put your hand in it and it doesn't hurt, is that good or bad? It may be okay the first 3 or 4 seconds, but then it becomes really bad because you don't feel the pain. So some people have that problem with their corneas and their eyes can be dry without feeling it. Even if your eyes don't feel dry, they may be, and it may need to be addressed. So oftentimes it's addressed with eye drops. However, your doctor may talk to you about something called an amniotic membrane. You may have heard of placentas or amniotic tissue. So this is amniotic tissue on a little ring on the right here is what we see, that is put in your eye like a contact lens, and all the really healthy proteins and everything else within that tissue then gets into your eye and helps heal your eye and may help restore some of the sensitivity. I just bring this up because this is something that oftentimes people think sounds really odd, really weird, and I wanted you to hear about it, so if your doctor brings it up to you, it's not a completely foreign or strange thought. Now, other than tears, there can be changes to your eyelid that can cause dry eyes, and so there are a number of pictures here to depict that. Sometimes we have flaky stuff along our eyelids and eyelashes, so people call it sleep in their eye. If you rub your eyes a little bit and you have all this flaky stuff, then one of these things could be the problem. It could be that the little oil glands along our eyelids are plugged up, and that's what my cursor is pointing to here. It could be something called blepharitis, which means inflammation of the eyelids and crusty debris along your eyelids that you see here. That over here on the right-hand side, you see it a little bit more easily. All those little flaky, chunky things, that's not supposed to be there. And there are drugs approved to treat these different conditions. There are different causes. Oftentimes it's bacteria, but blepharitis is a word you may have heard. It means inflammation of the eyelid. Different causes, therefore different treatments, and the symptoms are oftentimes very similar and or lead to dry eyes. Usually you as a patient will refer to it as flaky or sleep in your eyes or on your eyelashes. The treatments could be anything from as simple as warm washcloth that we hold and just kind of rub a little bit to kind of clean our eyelids and eyelashes. It can be lid scrubs that you may have heard of. There are different types of lid scrubs or lid wipes. There are eye drops to be used as directed by your eye care provider, over-the-counter or prescription. There's even sprays, something we spray along our eyelids and eyelashes to help with this inflammatory condition. Sometimes this inflammatory condition can be caused by bacteria, and sometimes by, believe it or not, little mites. Kind of gross, right? But as it turns out, there are prescription eye drops to take care of this. There's sprays we can use on our eyelids. There's in-office treatments. As it turns out, this is a very common and really typical condition that typical treatments usually don't work. How do you know if you have this? Your eye care provider should be able to tell you and then treat it for you appropriately. What is a stye? Well, the way I explain a stye is it's kind of like getting a pimple or a zit on your eyelid. Earlier I showed you the little glands along the eyelid, and a stye is basically when one of these glands gets plugged up, and the first course of treatment for a stye is heat. So really hot washcloth or one of the beaded masks generally can help treat it. Sometimes, however, we need oral antibiotics to treat a stye. What I want you to realize from this short presentation is dry eye disease is real and can be problematic. It can be really problematic. It can usually be managed and will be best managed with the help from your eye care professional. Not all drops, not all artificial tears are the same, so follow the directions of your doctor. Get a recommendation, a prescription from your doctor, whether it's for eye drops, a supplement that you take, like a vitamin like you would for maybe macular degeneration. But realize that dry eye disease is not related to macular degeneration. You may have either, neither, or both, but they're not related to each other. But dry eye disease is something that, especially if you have any symptoms, is something you should be discussing with your eye care provider, because there are some great treatments regardless of the cause. I want to thank you for spending about 17 minutes with me hearing about dry eyes. I hope you've enjoyed the program so far and you enjoyed the rest of the remaining to come. Thank you.
All right, we hope you enjoyed that. We want to thank you so much for coming today. We hope you got a lot of good information that you're going to be able to apply to your eye journey. We do have still our vendors in the back, so if you did any questions for them after hearing their presentations, please feel free to stop by and ask them some questions. Please turn in your evaluation form front and back. We do still have 5 cookbooks available, so if you're interested, please see Donna on my left, your